Hey guys, Dr. E here, and today we're going to be talking about hyponatremia, or low blood sodium. Now I get a lot of questions about this topic, and I think it's because it's so nebulous and there's so many different causes. But what I love about it is you can take it through a step-by-step algorithmic process to figure out what the cause of hyponatremia in your patient is. So the first step in evaluating the cause of hyponatremia is to check serum osms, or serum osmolality. This will divide your hyponatremia into three different types: hypotonic, where the serum solute levels are low; isotonic, or pseudohyponatremia, where the serum osmolality is normal; or hypertonic hyponatremia, where the serum osmolality is high. There's too many osmoles, too many solutes in the serum. So to start, hypotonic hyponatremia, where the serum osmolality is low, there's too few solutes, also known as true hyponatremia, has the widest differential. But the next step when you find out your patient has low solute hypotonic hyponatremia is to check their volume status. And volume status is a clinical determination. Is your patient volume overloaded? Do they have CHF or something that's causing them to hold on to water and get swollen? Are they hypovolemic, where they have low volume, their skin tenting, dehydrated, their oral mucosa is dehydrated, so they have hypovolemic hypotonic hyponatremia? Or are they euvolemic, where they're neither dehydrated nor volume overloaded? If your patient has hypovolemic hypotonic hyponatremia, then they have low blood volume, so they're losing volume, either from renal losses, so they're excreting too much from the kidneys, or extrarenal losses. They can have GI losses, where they're diarrheaing or vomiting and losing water that way. They can have a burn, where they've had a burn on their body and they're dehydrated, causing this hypotonic hyponatremia in a hypovolemic setting. Do they have fever, so they're very, very hot and they're sweating a lot, evaporating, losing water through that method? Or are they third spacing? Things like pancreatitis that causes fluid loss within the body. So these are your causes of low volume, low solute hyponatremia. Then we get to hypervolemic hypotonic hyponatremia. So low solute in the blood with hyponatremia with volume overload. Here we come with our three major causes of volume overload or edema. Nephrotic syndrome, where the kidneys are causing fluid overload with hyponatremia. CHF, where the heart is the cause, so they have congestive heart failure, and their heart isn't able to pump adequate blood throughout their body, and they're getting fluid overloaded, leading to hyponatremia. Or ascites, where they have portal hypertension or something wrong with their liver that's causing them to hold on to fluid and lose sodium and become hyponatremic. So these are the big three. And don't forget, with nephrotic syndrome, your major causes of that are diabetes and multiple myeloma. The other causes of hypervolemic hypotonic hyponatremia are beer potomania, where your patient is consuming way too much beer and not enough other foods. Psychogenic polydipsia, where your patient is overloading on water, drinking gallons and gallons of water a day, leading to volume overloaded hyponatremia. Or what we call the tea and toast diet. So the patient is just eating tea and toast and not a varied diet, not getting adequate nutrition, leading to volume overloaded hypotonic hyponatremia. Then the other volume status with hypotonic hyponatremia is euvolemic. They're neither volume depleted nor volume overloaded. Our causes here are SIADH, where the body's secreting too much ADH, leading to activation of those aquaporins in the kidney and then retention of water, leading to hyponatremia. Adrenal insufficiency, the adrenal gland isn't able to secrete enough aldosterone to cause sodium reabsorption in the kidney, leading them to have euvolemic hyponatremia. Or are they hypothyroid? They have low thyroid levels, leading to euvolemic hypotonic hyponatremia. Then our next category is isotonic hyponatremia, where they have normal blood tonicity, normal blood solutes, but still with hyponatremia. This is caused by hypertriglyceridemia, elevated triglycerides in the blood, as well as multiple myeloma, where they have too much globulin in the blood, too many light chains in the blood, leading to isotonic hyponatremia. The reason it's actually called pseudo-hyponatremia because the reason behind the isotonic hyponatremia is actually a lab error. These triglycerides and globulins are missing with the labs and causing them to appear hyponatremic even though they're not. And then the last cause is hypertonic hyponatremia, where their serum osmolality is too high, they have too many solutes in the blood, leading to hyponatremia. This is caused by severe hyperglycemia, so their blood glucose is way elevated, people with 300s, 400 blood glucose levels, and also people who ingest poisons. So there's some other solute in the blood that's leading to this hyponatremia. And that's really it. That's how you break down hyponatremia with these simple components. You start by checking serum osmolality, start by checking the level of solute in the serum. Don't forget that step because that's the most important first step, because that breaks it down into true or hypotonic, low serum solute hyponatremia, pseudo-false hyponatremia, where their blood tonicity is isotonic, it's normal, and then hypertonic hyponatremia, where they have something in the blood like glucose or poisons, leading to hyponatremia. If they're hypotonic, that's the biggest breakdown we've got, where our next step is to check their volume status clinically. Are they volume depleted, normal volume, or volume overloaded? If they're volume depleted, they're either losing fluid through the kidneys because of some kidney issue, or they're losing fluid through something outside the kidney. They're diarrheaing or vomiting, or they have severe fever where they're getting very dehydrated and hyponatremic. Are they euvolemic, normal blood, a normal volume, they're neither dehydrated nor fluid overloaded, or either they have ADH, adrenal insufficiency, or hypothyroidism, or are they volume overloaded, where they have one of the big three causes of edema leading to hypotonic hyponatremia, nephrotic syndrome, CHF, or ascites, or one of these psychogenic causes of hypervolemic hypotonic hyponatremia. And that's pretty much it. That's how we break down hyponatremia. Any questions, let me know in the comments section, and good luck studying, guys.